was asked to talk about the behavioral problems of dementia. I've been consulting at nursing homes my entire career, and for mostly these sorts of things for behavioral problems. But so let me, I'll just tell you that I have no disclosures. I have no conflicts of interest. I would like to give a particular acknowledgement to Dr. Wallazek, and he's a professor of psychiatry. He's from the University of Wisconsin. He also has to do with the Alzheimer's Institute and Research Center and residency teaching. And he published this book that I think is just really a wonderful book. It's relatively small. It's easy to read. It's well written. And it's recent. It came out just 3 years ago. Really, I think if any of you are working in the area of patients with dementia, there's just lots of helpful ideas about this. And it's not just targeted toward physicians. There's several chapters that involve some very specific ideas and suggestions that you can use both yourself as well as family members. I'll pull out a few of those during this talk, but I encourage you to consider this as a source. I also wanted to just briefly tell you about the person that got me into geriatrics. Dr. Saslow, George Saslow, was the founder of my psychiatry department out at OHSU in the 1950s. He got his MD, PhD from Harvard, and then came out to Portland to the West Coast in the 50s. And at the time that I trained with him, he was 83 years old. He actually practiced medicine until he was 95. And as you can see, he lived until he was 100. He lived independently at that time. And Dr. Saslow really inspired me to consider geriatrics as an important part of my career. There's many things that I learned from him, but I'm just going to give you a few of his words of wisdom. So number one is that he really very strongly felt that we should see patients, particularly elderly patients, where they are, where they live. And so with him for a year, he and I went to several different nursing homes on a weekly basis and saw the patients in their rooms, in the hallways, in the environment there. And I've continued that through my whole career. Every week I go to nursing homes. I was always impressed by Dr. Saslow because he would, when we would go and talk with people, and yes, we would absolutely talk to the patient, and we're very interested in the family and their point of view. He spent an inordinate amount of time talking to aides, and because in fact the aides are the ones that spend all the time with the residents or the patients, and they in fact know more than anybody else when it comes to, particularly at the nursing home. But so he just thought it was terribly important to listen. And different people see things differently. Then he just really felt that it was important, especially as a physician, but really with all of us as healthcare providers, is that we need to provide education. That we need to help people understand things. So our objectives today, I'll give you a brief introduction to dementia. We'll talk about some of the common types of behavioral and psychological symptoms of patients with dementia. We will review some of the standards of care in approaching these folks. And then I did break out some specific symptoms about some specific interventions that we could talk about. So this slide is the silver tsunami, the tidal wave of aging people in our country. So as you'll see from 1900, in 1900, there was only 3 million people over the age of 65. Dr. Jurovich and I are less impressed by 65 as considered to be elderly. But in fact, if you look at the lime green, so the middle, this is age 75 to 84. And then the deepest green of the age 85 and older. And so you can see that in 2000, and this continues to increase. So 20 years ago, there were already more 85 plus year olds than there were anyone over 65 in this country. So a spectacular explosion. As well, unfortunately, since a substantial risk factor for developing dementia is decade of life, that you will see, and the pink is women and the blue is men, and that you'll see, so this is worldwide, the increases in the individuals with dementia. And so over these next 30 years, you can see that they're just continuing to go up. So the estimate of 139 million people with dementia, again, worldwide. In the United States, this is increasing as well. So in the United States, we're estimating that number will double from 6 million to 13 million. In the world, it's particularly the lower and mid-income families, so that's the pink, is really accelerating greatly. Let me just see if I can, there we go. And so this, again, is going to be a huge problem worldwide. So the definition, so in psychiatry, we have this kind of unusually named textbook called the Diagnostic and Statistics Manual, and this is the 5th edition. It's just a very strange name for what is essentially the names of all of the psychiatric illnesses, and the diagnostic criteria for them. And so when it comes to dementia, just kind of to simplify, this is something that's acquired, it's persistent, and it's a decline in a number of areas of intellectual abilities. Now, we're the most familiar with memory, but also language or visual spatial, problem solving, or then what we'll talk, executive functioning, that ability to plan or decide, attention, as well as then even to recognize people and perform complex tasks, and that it causes functional impairment. So DSM talks about mild to major. So the term they've stopped using dementia, which is really frustrating to me. They call it major neurocognitive disorder. So all of the rest of the medical field still use dementia, but psychiatry doesn't. But I do. And so when you go from mild to major, some of the real hallmarks is this activities of daily living. And so there's 2 primary clusters. So the more complex kind is the instrumental activities of daily living. So shopping, the ability to shop for groceries or clothing or household things, housekeeping, managing financings, being able to prepare food, and then transportation. All of those, while those are things that we're all doing regularly, those have a significant amount of brain power in order to do those things successfully. Less complex than are your personal activities of daily living. So dressing oneself, so putting on my own clothes, picking my clothes out and putting them on appropriately, um, feeding myself, being able to walk, being able to go to the toilet appropriately, and then to be able to take care of personal hygiene. So this is, I think this is an oldie but a goodie. So Dr. Reisberg has been working in the field of dementia for decades, and he called this a global deterioration scale, and then he flipped it and called it the functional assessment staging scale as well, the FAST. And what I just want to point out a couple of things for us. So the Folstein mini mental state, that's a common cognitive screening tool that has been used over the years. And so you can see how these scores drop off. And as you get into the later stages of dementia, you can see it's really a useless tool once it gets really significantly impaired. The second thing to note is the degree. So mild cognitive impairment. So this occurs over many years. So 74, or excuse me, 84 months. So that's 6 years at least. And so when we think of even the total span in Alzheimer's, that this is a 10, 15 plus year illness. Now, I personally meet most of these patients when they're in the moderate, most commonly in the moderately severe, because that's when the impairment really starts breaking down as far as the ability, the amount of care that's needed to help take care of them. And then this coincides with a lot of the psychiatric difficulties, the stage 6. So this slide just reminds us that because I have one kind of dementia, that I'm not immune to other kinds. Just because I have diabetes doesn't mean, so then I can't have hypertension, or I can't have COPD. No, and so those run together all the time. Well, the same thing. So if I have vascular risk factors, that in fact then can confound my Alzheimer's. So, and when we have these overlaps, I can tell you nothing good happens by overlapping, but it's always worse in overlap. So while we have many that would have, fairly pure Alzheimer's, there's again many that have overlaps. When you think about a comprehensive plan to address dementia, so Dr. Walsneck lists a series of items I think that are very sensible. So certainly initially the idea of the diagnosis, and part of that would include a medical assessment, because you want to rule out certain medical causes of dementia that are potentially treatable. And then early on, it's teaching the family and the patients about this illness, and then supporting them through the course of it. Addressing the caregiver needs, huge thing. As the caregiver burns out, then the shift of cares, the additional needs, just really become much more severe. And then if there's things that we can do to delay cognitive decline, that might involve some medications, certainly exercise, cognitive stimulation, Mediterranean diet, and others. Those are all reasonable things to try to do. Strategies that we can do to support their ADLs. In order to, oftentimes this has to do with trying to, how can we keep them going there at the home front as long as we can? And then if pain is an issue, if there's other medical problems that are going on that need to be addressed, because again, they will negatively impact the dementia, the behaviors. A safe environment is terribly important. As a caregiver, if you have a person so that they're at home, that you're looking after your loved one, that just in the same, when you think of the toddler, the 2 and 3 and 4-year-old, that there's a whole bunch of dangerous things that whether it's cords or plug-ins or sharp edges on corners, things that when we safety proof for a youngster, in a similar fashion, we may need to safety proof the environment for a person with dementia. And then advanced planning that includes things like powers of attorney, guardianship potentially, but hopefully if we can plan it in advance, then it's much easier to do powers of attorney. And then when these behavioral difficulties are occurring, then what can we do about them? Okay. So I'd just like to we'll talk now about some of these common types. What will we see? So this is a slide that shows in these 3 very common neurologic illnesses, and this is the age of the patients. Okay, that you'll see that each of these has a pattern. Okay, so in the light blue, the patients with Parkinson's, they tend to have at a younger age have a lot of the behavioral problems, the psychiatric difficulties occur at a younger age with Parkinson's. Partly because their lifespan is limited after the diagnosis of Parkinson's disease. Alzheimer's, the number 1 risk factor, is decadal life, and so it's not surprising that as the decades go, that we increase in behavioral problems. And then our risk for strokes typically just kind of gradually increases over our life, but not anywhere near as jumping as Alzheimer's. At some point in their experience with dementia, 90% of patients will have some of these behavioral or psychological symptoms. So those symptoms include anxiety and depression, irritability, paranoia, hallucinations, verbal aggression, physical aggression, apathy, and disturbances of sleep-wake cycle. And we'll talk in more detail. So depression. So the patients with dementia that present with depression, they'll have some of the classic criteria. So lack of interest, lack of motivation, maybe diminished appetite, tearfulness, sadness, suicidal thoughts. Those are at the highest risk when their dementia is the mildest. As the dementia progresses, then that drops off greatly. A lot having to do with just the lack of self-awareness. These self-report measures that we do, so here in the clinic, we do PHQ-9s, which is it's actually just it's the 9 diagnostic criteria for major depression on a little scale when you go to the clinic and people fill it out. Well, the more that the dementia progresses, this is a self-report, so it's a very unreliable then over time. Apathy, very common early presentation of dementia. Just lack of motivation and interest, less affectionate, just not engaging with other people. Many times the family just don't understand that. What's different? Why is this happening? And oftentimes this is running ahead of the real easily seen memory problems. Verbal aggression can be screaming, swearing, perseverative statements over and over and over, moaning. Physical aggression, there's a wide range, but it can absolutely be hitting, kicking, biting, slamming, pacing, restlessness, wandering, and also being sexually inappropriate. Sleep-wake cycles are very commonly disturbed. And many times they'll be flipped, sleeping during the day, up all night. It's a very common pattern of Alzheimer's. With other conditions like Lewy body dementia, there's a very particular association with what they call REM sleep behavior, that's our dreaming states. Now, normally when we dream, we're paralyzed. We have no motor movement, and we're just doing the dreaming. But in patients with Lewy bodies and to a degree with Parkinson's, that they will have the physical responses to what they're seeing on the dream. So it can be very agitating to be right in the middle of a frightening dream and sundowning. Anxiety and irritability. Many patients in early to moderate dementia will be very worrisome. They will be very frightened to be alone. They'll be glued to their loved one. That they don't even to be out of the sight of the loved one is frightening and worrisome. And the fear that they would be abandoned. That a small thing, very small thing, can become a catastrophe. And you can see how wearing that this would be on the loved one. That you're literally like glue to them. I've had many 80 and 90-year-old caregivers be accused by their spouse of 70 years that they're being unfaithful right now with somebody that's like 20 years old or something like that, especially like it's a caregiver that comes in or something. So the paranoia, the blaming about infidelity, misidentifying that you are not my spouse. Yeah, you are not you're somebody that looks like them, but you're not them. They've been replaced. And then visual hallucinations, especially with Lewy body dementia or with Parkinson's, that as they're being as the Sinemet and those meds near the end stages of Parkinson's have to be pushed. It's very common that they'll have very vivid hallucinations that are frightening and alarming and that they will respond to. Euphoria, disinhibition, elation, being socially inappropriate. Those will be especially when the frontal lobes have been hit, and whether that's because of a traumatic brain injury, because of frontal temporal dementia, frontal strokes, or a patient that previously was bipolar and now is developing dementia. And so it can be very challenging. Pathologically, crying and laughing. I'm not, that any kind of strong emotion or even just a general statement, then a person may burst out in tears or be either crying or laughing. And then you'll ask them, so they're crying, are you sad? No, I'm not sad. I can't help it. And it just will happen that, and so there's a number of neurologic illnesses, but frontal temporal dementia. We see it with traumatic brain injuries, ALS, and also with multiple sclerosis. can be it's very upsetting, especially to the family, even more so than the patient, because we identify what we see with an appropriate affect, and these are disconnected. Most patients with dementia, especially Alzheimer's, lose sense of smell and taste. So things don't taste good. They lose weight. The one subgroup, the frontal temporal, the patients with a frontal injury, then they be just the opposite, that they see it and eat it, and will eat excessively and be kind of excessively oral. We do want to be careful that some of the treatments that we use to try to help preserve memory, these acetylcholinesterase inhibitors, that the primary side effect is nausea, GI upset, or weight loss. And so that's running right at the same time. There's times that we may have to just try to sort those two out, or back off, or switch to a transdermal option, so a skin patch. So the prevalence of these specific kinds. So half of the patients with dementia will have apathy. Half will. Nearly as many will have depression and aggression. And you can see, very substantial numbers in these areas of the troubles that we were just talking about. The euphoria is less common. The hallucinations are less common, but very troublesome, as well as the delusions. And interestingly, what this, it's a little bit busy, and I'm going to apologize in advance. I'm going to give you the busiest slide, the next one. But the way that we're going to read this is, so if normal, mild, moderate, severe, that as the dementia progresses, okay, we get we get more people that have 3 or more symptoms. So you don't get just one, you get clusters of them. And in fact, so in severe dementia, we have a small percentage that don't have any of these symptoms at all. And so substantial number with 1 or 2, but even a bigger number are having 3 or more. The way that this is the slide I'm going to apologize about. And so, but what I just wanted to show you is, so again, mild, moderate, severe, you can see the prevalence of these. So if we just follow over, so delusions, agitation, depression, apathy. So you can see how these are jumping compared to prior to the progression of the dementia. And the most common symptoms can vary based on the cause of the dementia. So Alzheimer's is the most common kind of dementia, that early, so depression, anxiety, and insomnia. Okay, so it can be misdiagnosed if we don't ask and push a little further into the cognitive exam. The more severe, then we get the aggression and the repetitiveness, as well as the psychosis. Lewy body, early, we get visual hallucinations and delusions and the REM sleep problems. With vascular dementia, we have an overabundance of apathy, amotivation, and depression. We talked some about frontal temporal. And so then, in our frontal lobes, then if we lose our frontal lobes, and disinhibition could be apathy or impulsivity. Many times it's more impulsive. And the hyperorality, the excessive eating everything on my plate, the plate across the table, everything that I see, I do. Patients with Down syndrome get the double whammy that they have, for the most part, so they have a very early onset Alzheimer's disease, commonly in their mid 30s, sometimes even earlier, but mid 30s to 40s. Some are at increased risk for vascular disease. And then they had, before this, then they had the intellectual impairment secondary to their syndrome. So it's a double and triple whammy that you see with Down syndrome. So the impacts of this, well, this reduces the quality of life for the patients as well as the caregivers. It clearly increases the burden. A third of caregivers have depression, nearly half have anxiety as they're trying to take care of their patient, their loved one. There's a risk of elder abuse. It's much more costly. And then these are things that commonly overwhelm the caregiver and then lead to nursing home placement. I would say that myself, the two biggest things that I've seen that end up with nursing home placement is number one is that the caregiver gets burned out or becomes medically ill because of the strain, has increased medical problems themselves, or then the either aggression or the amount of care regarding the incontinence, and that just becomes much more overwhelming. So why do we have these? Well, we don't know for sure, but there's been several different ideas that have been put forth. So psychologists love this ABC. They like it for all things, not just in dealing with dementia, but so, what was happening beforehand, what are the specific behaviors, and then what were the consequences of the behavior. A second model has to do with that the person's ability to handle stress changes when other events happen. So they become more tired, or if there's changes in their routine, or that they have medical problems on top of it, or they have medication side effects. That in the past, when they were able to mostly maintain this behavior, now when these other events happen, then the behaviors break through. And the third is this unmet needs model. The idea that if I have substantial cognitive impairment and language impairment, I can't tell you that I need something. I can't tell you that I'm hurting, that I can't communicate this. And so it comes out in behavior instead. So as we try to help folks, and particularly the caregivers, with this, these are the sorts of questions that we would ask. So what is this behavior? How long does it last? How severe is it? Is there any kind of precipitants? Is there any triggers that we can figure out? They behave primarily, so with women caregivers, these events are more likely to happen, or with male caregivers, these events are, is there any kind of connection that we can make? And how do people respond? And does that seem to help, or does it seem to exacerbate it? And then is there something new? What's different now than in the past? Why is this different? A number of factors. So if I'm having an infection, if I've had a new stroke, if I have severe constipation, urinary retention, I've had if I have a abscessed tooth, if I have extremely impacted earwax, if I have an ingrown toenail, that there's many things that can make me uncomfortable. There's certain medications that can add to troubles. Medications that are very drying, anticholinergic medications can that make you more confused. There's certain medications that can lower your sodiums or can cause you to be restless. Um, Alcohol doesn't do anything good for patients with dementia. Are they bored? Were there were there past events? Did they have pre-existing psychiatric troubles now that are compounded by this? Um, is there financial stress? Is there disagreements among the children? Um, Cultural factors, the role of the family. So there's multiple things that can go into this. So this is a model that Kale's described about. So if we're going to investigate this behavior, let's try to get the caregiver to describe it. Let's see if there is some sort of cause. Let's figure out a treatment plan, and then we'll go back and see if has that made any difference. So just kind of a problem-solving way to try to manage it. So as we've said, we're going to try to address any kind of contributing medical or environmental factor. If there's any medications causing trouble, we're going to be particularly watchful for pain. We're going to train and educate and support the caregivers. Actually, in a number of the studies, that caregiver training itself is one of the most important things that we can do to help people intervene. We'll talk some further about behavioral management and then medications. I'm only going to briefly touch on that today, but really we use these only if we can't get there or that they're so dangerous. We try to watch over polypharmacy. Too many medications just add and compound troubles. The benefits regarding medications are modest at best, and there are definitely significant risk factors. At the time I initially made this slide, I said there was no FDA approved. As of this year, there is one drug that's approved for agitation associated with dementia from Alzheimer's, but it costs $1,200 per month. I've never personally started anybody on it because it's just too expensive, and it's frankly not spectacularly effective. So as a summary, we're going to treat underlying conditions. We're going to, from the medical perspective, we want to make sure that is there any offending medications or substances. We are definitely going to support and educate people. We'll try to figure out a management plan that might include some environmental changes, behavioral changes. We add meds, we're going to do them very carefully. If we do, these are some medicines that can be beneficial. If we do add a medication, we're going to monitor it regularly, and we're going to try to stop it when we can. And we're going to make sure that we have a safe environment. So some specific advice to caregivers. So for the family themselves, the family caregivers, as they're going down this road of looking after someone that is progressing into dementia, they just have to be able to be flexible and improvise. It just can't, the same thing just can't always work. Understand that when the patient tells them these terrible things, that they just can't take it personally. That person isn't the same person. They're being robbed of that person by their dementia. When you can, allow them to have as much control as they can. That they can that even small things like getting dressed for the morning, that instead of wear this, to give them a couple of options and let them choose. And so which of these things do you want to do? They won't have a choice of not doing it, but um, you know, that that makes a difference. Be realistic. As it progresses, more help will be needed. It just will be. So advice regarding, so with, as the family member tries to communicate with their loved one with dementia, don't try to reason with or convince a person with dementia of something. Um, when you keep the questions and the responses and the instructions simple, often one step, not if you do this and this and this, three-step commands just don't go well. Speak more slowly, give more time to respond. Try to be calm and positive. Try to be reassuring and encouraging. That negative words and tone and facial expressions are agitating to the person with dementia. They may not fully understand what you're saying, but they will perceive your body language. So you just it's very challenging, but to try to stay calm. Patients, the family caregivers will be the most successful with their patient, with their loved one with dementia, that the more they keep them in a routine. If there is challenging things like bathing, that that over time you learn that it's, boy, I'm going to have the best chance at this in the afternoon, or not right away in the morning, and not that it'll be kind of by trial and error, but you'll find the times that these challenging things. So don't do it on your schedule, but find a schedule that works best for that person. You can schedule pleasurable activities, but you can overload people with dementia. And big family gatherings, weddings, reunions, holiday gatherings. Boy, many times that becomes overwhelming with the patient with dementia. I've had patients that that there was a loved granddaughter that's getting married, and instead of having the patient with pretty profound dementia be in the big church and all the commotion, that instead just individual pieces of the of the day would come over to the hotel room and just spend a little time with them, just kind of one-on-one or two-on-one. Much more successful. Think about some meaningful activities that they can do. Folding laundry, setting a table, that sort of thing, that can be interesting and helpful. For the caregiver needs to be able to look after themselves too. They need to be careful about their alcohol and caffeine. They need to exercise. They need to have to eat well. They need to get sleep. They need to not skip all of their medical care. They need to be watchful of signs themselves being burned out. They need to take breaks. Home care services can give 2 or 3 hours here and there, or somebody coming at night so you can for sure sleep. Adult daycare, even 2 or 3 days a week for 3 or 4 hours can make a huge difference for the caregiver. We have support groups in the area for caregivers. The Memory Cafe, Alzheimer's Association, a number of others are just wonderful supports. The caregiver needs to still schedule activities with friends and family. They can't lose their life. So the kind of interventions that are the most effective is becoming more trained and educated, the caregivers themselves to have structured activities. Music therapy can be helpful. Things like massage or these sensory interventions can be helpful. Reminiscence therapy. Patients can have quite profound dementia, but they can very much enjoy looking at pictures or magazines from the 1930s and 40s and 50s. They will remember those much better than something that happened today or yesterday. Dementia care mapping, it's especially common in Europe, where they have psychologists right in the nursing homes. So Dr. Jesse just reminds us that there's just not a lot of data out there, and we just don't have really terrific medication interventions. So our last area, I just wanted to give us some very specific symptoms. So dementia and depression. So depression and dementia just doesn't respond as well to antidepressants. If you're really in a pickle and if it's really severe, ECT can sometimes be used, but usually we don't do it because of confusion and delirium. Exercise, reminiscence. The pseudobulbar that we talked about, actually, there's a medication that can make a fair difference for that. Although education helps too with that, with the family, just to realize that the family, that it's not the severe, just because mom is crying and tearful, it doesn't necessarily mean that she's severely sad. Suicidal thoughts are most troublesome early, quite early. Hallucinations and delusions, and I just wanted to say in the non-Lewy body, people that actually many times you don't necessarily need to do anything about this, because many times people will talk about these strange experiences, but they may not be upset about it themselves, and so if that's the case, boy. Then if we can educate the family, if we can use distraction or diversion, that's frankly safer than giving them an antipsychotic medication. Many times these are connected to very poor hearing and very poor vision. I try to hold off on an antipsychotic medication unless they're reacting to them in a dangerous way, that they won't eat because they feel the food is poisoned and that sort of thing. But these medications are not nearly as effective as they are in young people with, like, for example, schizophrenia or something. Sexual aggression is very troublesome and upsetting when that happens. And that can include a number of kind of behaviors. We try to make environmental interventions if we can. Put them in a single room. If it has to do with the young women that are taking care of them, if it's a male, then we try to get male caregivers. We try to use redirection, distraction. We've modified clothing to men that were masturbating in public. All of a sudden, that we put them in bib overalls and sewed up the zipper, and that was helpful. We can use medications. They can be quite helpful, but usually we try these other things. Wandering. So this is a bracelet that can activate a lock on the door of a facility. This is actually a cover for a door, make it look like a bookshelf. This is a little Velcro netting, and actually this isn't to keep the person from escaping the room. This is to keep a wanderer from going into a room that they need not be in. And You can have profound dementia and you still know what a stop sign is. So there's a number of things that can make a difference there. We cover the elevator switch at one of the nursing homes that I go to. So you have to just slide it up and then push the button, and it makes a big difference. Sleep disturbances, sleep changes as we get older, and they're worse with dementia. So, as best we can we keep them up during the day, have activities, try to help that day-night cycle. There's some medicines that can be of some benefit, but we have to be careful. With apathy, there's not a lot of information, but interestingly, music therapy or these having a pet, a number of nursing homes will allow pets to come in or even keep pets there. Medications haven't been that great. The anorexia and the weight loss, again, when things just don't taste well and I just lose my appetite, there's certain medicines that we have to be careful of, that we're not making it worse. We try to help supplement, and there's a medication that can improve appetite with some folks. So I showed you this slide earlier just to remind us that we are trying to treat the underlying cause. We're stopping offending medications. We are educating and supporting. We're trying to get a treatment plan. We're being careful about medications, and we're trying to make sure that it's safe. So, in conclusion, we've talked about these three things as our objectives today.